Welcome everyone to today's webinar with Dr. Paul Fugazzotto. My name is Shane Shuttlesworth and I'm the president of Osteogenics. Before we get started, let me address how we will be interacting today. From a technical perspective, we can't hear or see you, but we would love to hear from you and be able to answer any questions that you may have. There's a Q&A button on the right hand of your screen where you can type your questions at any time and we'll try to get them answered during the webinar. I think it'll be towards the end of the program. Quick introduction, Dr. Fugazzotto, I assume many of you know who he is. He is a periodontist in private practice in Milton, Massachusetts, in the Boston area. Has probably more experience than anyone else in the United States using titanium reinforced PTFE membranes for big vertical ridge augmentations. He has a ton of experience. He also runs the Fugazzotto Institute where they do live courses. He's also a personal friend and at least a mediocre fisherman. Paul, thanks for being with us here today and doing this.
You're more than welcome, Shane. Thank you so much. And the fishing has been fun together, I have to admit. So let's talk a little bit. We're going to spend a couple of hours talking about what has become a mainstay in our practice. And I say has become because it evolves, but we've been doing significant regenerative therapy with titanium reinforced membranes since 1990. And it's something we do all the time. Of course, we use resorbable membranes as well, but I would say 70% of what we use are titanium reinforced because of what our definition of success going guided bone regeneration is. And we'll go over that. It's actually different and much more demanding than what is commonly accepted. And there's a reason for that. We'll talk about that afterwards. So what we're going to do first is we're going to do a live surgery on a patient. A maxillary anterior area, perfect spot for titanium reinforced membranes. One, because it will fulfill my definition of success after therapy. But two, because this area is also often treated in other ways. We'll talk about why we don't do that. We'll review flap designs, etc. So I'm going to go down. We're going to get the patients ready. I'm just going to robe up and we'll get started. We'll do the procedure. After that, we're going to go through only a few slides to show you some incision designs. Then we're going to do question and answer. I'm a full-time clinician. I'm a very straightforward person, and I'll tell you what has worked for us and what doesn't work for us. And I would suggest that you go fishing with Shane, and then afterwards, when you want to learn a higher level of fishing, go fishing with me. Okay, I'll see you in a couple of minutes. Okay. The tugging I have to do not because of the camera, because I need access. I'm going to angle that, please. Thank you. Jackie. I knew that. No, I'm just kidding. So good that when your jokes are this bad, no matter what you say, people say, okay, you know, we expect it. Okay, you all right? Now I have to do some tugging. This is because of the scar tissue, okay? Bear with me, all right? Is that okay? Thank you, Aaron. Would you like to hear something terrible? The gentleman doing this on the other end, when he introduced me, said that I was a mediocre fisherman, even though we've been fishing together. And we went in. I didn't want to be embarrassed, so I took one of my big fish and put him in his basket so he wouldn't feel so bad. And he had the nerve to say that. Do you believe that? It's the way people are sometimes. There we go. Almost done with the pushing, okay? Very just because I'm a pushy person. All right? There we go. Beautiful. Perfect. Very patient. Thanks, sir. Want a chair around? You're welcome. You okay? Okay. You're a great patient. That's not a thermonuclear device. Does that hurt? Let me just stepped on something. Don't worry. Mine's not up. Okay. Let's take a look. Again, you just have to clean all this out where this had all happened. Okay? Beautiful. You're welcome. What do you guys think? Great. For a kid, which nobody called me, by the way. So, okay. Can I get it? Okay. Thank you, young man. What a young man. Hope everybody heard those young mans. Suction, I would hope so. We suction. Thank you. Vertical. No pain. Okay. I'm going to keep asking, kiddo. Pardon me? Thank you. Little pressure now on the inside, okay? Thank you. You okay? I will have to, because I actually made the mistake of looking for an instrument thinking I wouldn't have already had it in his hand. It was just foolish of me. There we go. You okay? Notice, although there's pushing, was a little more pushing on the outside because that's where most of the scar tissue was. You're doing great. Beautiful. You okay? Okay. By the way, I'm okay too, but nobody's asking me, which is a little disappointing, but good. Suction from that. Okay. And the palatal wall that's slightly decreased in here. I'm just going to clean out any scar tissue. It'll be like almost like getting your teeth cleaned for a minute, okay? And you're more than half done with the whole thing. Are you going to miss me? Thank you. That was really I feel great. I feel great now. Very convincing. I'll just do it. Where might that be? But if it's a wave, don't. Okay. Hold on back to the thing. That's the cleaning out any, hold on a second. Cleaning any stuff out, okay? I'm going to rinse your mouth for a second, all right? Are you okay? Okay. You're doing great. You need to do 15s after you're done. Okay. Hold on. Hold on. Suction freezer. Thank you. Behind me, please. And then we're going to start to put you back together, okay? Thank you. Okay, thank you. I'm going to push. You have to tell me if this shouldn't hurt at all, but I'm going to keep asking you. That hurt at all? Okay, now I'm clearing off the last little bit of scar tissue, okay? And then we're ready to put everything back together. What a shame, I know, but amazing patient. I'm serious, amazing patient. But if you're going to mumble, I'm not going to talk to you. I mean, come on. I have a new 15. Take that out, please. Let's look at this. Mobility is not yet where we want to be, because that would collapse. So we're going to get more mobility. There you go. Put the other one back in. I'm sorry. you. Thank you, Dominique. This section right here. So horizontal extension, which we'll talk about. That's one of the keys. Okay. Stay there, please. For the your side, please. Okay. Thank you. You okay, kiddo? Okay. So you have to try that restaurant I told you about. It's fantastic. I'm trying to distract you, obviously, but it's fantastic. My favorite restaurant, French restaurant, Boston, is Wow, because they have an amazing dough store, but this place is much more interesting. It's really cool. You know who Lydia Shire is? She was a pretty famous, one of the doyens of all the dining here, starting in the 80s. We sit down, she sat down next to us. We ended up talking a little bit because I know it was somebody else. And you know that she had the pastry chef from the restaurant sitting with her. So you know they're sending over trays of pastries to try. We need your opinion on every one. So are you kidding me? I already weigh 8,000 pounds. I eat one, okay, that's 300 sit-ups. I eat another one, that's 300 sit-ups. You know? Okay. Now let's take a look. Take that out, please. Just with that simple extension. Look at the difference. I'm going to put a piece of cotton in for a moment. Actually, can I have the membrane first? You have a college prior? Thank you. I'm going to go back and forth with this. That does not mean anything's wrong, okay? I'm just fitting it. You suction, please. Turn toward me a little. Think of it as bespoke bone grafting, okay? You okay? Okay, you rest a minute. This new, all trimming is done with a 15 unless you're going to go to the titanium. Thank you, Air. Have a membrane? No, I don't think I'll need 5. I just regular. Thank you. Okay. Let's start to trim this a bit for you, okay? Cytoplast suture, please. And chromic on the verticals. Okay, we're going to go back and forth here now, okay? Open, please. Thank you. When you're going to curl it, you take an instrument and you curl. That's simple. Let's look. Okay, again, I'm just fitting. I want to get this exact, so I have to go back and forth 3 or 4 times, okay? I just don't want to think anything's wrong. If you hear me say get the plane to Mexico, then you'll know something's going on, but oh no, okay. Got a lot of trimming to do, including this way. You don't want to be touching the teeth. Right there. I'm going to push a little there. Okay, I'm going to push a little for a second, make sure nothing hurts. More interior, please. Good. All full thickness. No pain? Okay, kiddo, we're just about finishing it up. I'm going to get up here too. Thanks. Suction. Good. On your height there. Beautiful. No pain, correct? Okay. Okay, can I have a 15? Again, it's right here. Thanks, sir. So when you do these little fine adjustments, it makes no sense to do with a scissors because you're much more control with a 15 blade. That's what we do. Okay? Okay. Almost done fooling around with this thing, okay? And then we'll get this over with for you. Can I have a scissors, please? Scissors. Go through the titanium, use the scissors. Nope, just particulate, regular particulate. Yep. Thank you. Okay. Reflect for me. Yeah. Yep. Can I give you this? I'm not sure yet. Here you go. Take you through them. Oh, I can check this. Thank you. Let's see where we are now. Where we want to be. I'll trim that little tag in a moment. We're going to get back our ideal ridge form. We don't have to, here, remember, we've got a little deficiency, so I have to tuck up like so. We don't always have to do that, but we do in this situation. Here we go. Ideal ridge form. I've got to trim here a little bit more. Release, please. Perfect. Here you go. Okay, I'll show you what we're talking about. Take that away a little, and then we'll do, after we tack it, we'll do what's called a secondary reflection. Okay, perfect. You okay? Last little trimming. And I sound glad we want to do that stuff to me. I'm just being really, but you know, so it makes it work. Oh no. Oh, I mean, that's just, that should be part of the deal, right? You're very easy. You're welcome. That's true. You guys agree?
Right.
Oh, you succeed.
Sounds about right.
Okay, let's take a look. I want to look at that damage. Oh, okay. I'm going to rinse this, okay? Here you go, man. Look at the adjacent root surface first, okay? And this is totally normal level of attachment apparatus. Here we've had some bone loss here. I'm going to put a protein on to help get reattached, like we talked about, to get the gum up higher on there.
Okay.
Okay. So take over the membrane once more, then we'll finish everything up. Structural end again, yeah. 0.3. You got it? Thank you. There we go. Release, please. I gotta trim it down here because I'm on the nasal spine. Okay, you rest a second. Almost done. I'm gonna put a little stuff, for lack of a better word, on the root. It cleans off any little bacteria so we can get reattachment to the root. Tastes kind of cruddy, but it's only for 30 seconds, okay? Then I'll put a protein. Then we'll secure this little membrane with some tacks, put the calcium material, some stitches, and throw it out. A little over 10 more minutes, okay? Is that okay? I'm glad you said that because that's what I got to do. So if you say no, we got a real problem. If you say no, let me put it that way. Okay, can I have a quick? Are you okay, sir? Okay.
Yeah.
Little water, and then I'll take that from capture off that off here. Use the cabbage one. Still have it here. Thank you. Thank you. Little, I'm going to make sure there's no little bacteria. What is that? From what? Oh, okay. Okay, a little bit of water. Okay. You okay? Good. Okay. Now yeah. Your suction right on there. I don't know what that was. Okay. Gonna put kind of yucky for 30 seconds, okay? Fresh gel, then we'll put some Emdogain, and then we'll go back to our result. No, I'm gonna put that on the root surface. And then we'll tack. Actually, what I'm gonna do is I'm gonna rinse, then we'll tack the membrane down, do all this stuff. Okay. That has to soak in a little bit, okay? You okay?
Mhm.
What'd you say? A better patient than me. And I'm a loser as a patient anyhow, so I don't know what else to say to you guys. Okay, all set? Here you go. Thank you. Stay right there, okay, kiddo? Okay. Your tax, right? See how we want this positioned. It's gonna end up being like that eventually. Good. Perfect. Okay, right there. There's gonna be a little tapping. I have to secure this membrane, okay? This is a little weird. I know because I had it done in my mouth and it was a little weird. So. Let's do it on the right on the spine here. A little weird, okay? Here comes a tap. Well, you wonder what the heck I'm doing. I'm just securing the membrane, okay? That keeps it from moving, so you get back all the bone we want you to get, all right?
Mhm.
Have another one left. Thank you. Stay right there, please. Because as you and I talked, I'm not sure where you'd be going. But turn toward me. Hold on, let me take this for a second. I'll see what I want to do here.
That's a good deal. Thank you.
Mm-hmm. He's very mean, as you can tell.
In there again.
Well, I'm going to have to for a second. So I'll go away. Just kidding. Thank you. Sort of. Bite down, please. I'm just going to punch you in the nose with the mirror for fun, okay? Are you okay?
Mhm. Compliments you. How much you do?
That
It's a
wasn't
rewarding.
trying to relax. There. We just have to really tug up here, okay? You get position on that. Where we want to be. That's not going to be in the way. Perfect. Okay. You okay?
Mhm.
Take that, please. Moving that. There we go. Little tap. Ready? Thank you. You gotta get this side, right? Yep. Thank you. That's the technique. You hold it and roll it off. You never pull it up. Okay. Now we're gonna put some calcium material and stuff and finish this up for you. Okay? Are you okay?
Mhm.
Okay. Do you want a break?
Mhm.
You really don't want to hang with me, huh? I don't blame you. Always a minimum of 2 tacks. Minimum. There's the space we want to create, which we will. The biggest thing is going to be the line angle, as you'll see. Can I have the prep gel, the Emdogain to put on the root? I'll give you this. Thank you. Thank you. I can just go like this and get it. Put the extra out. All I'm doing is putting some Emdogain on the root under here, where we just were. Well,
Right there.
actually, thank you. I'll use this one. You go, Dominique.
What is it?
Trying to get in on the act, huh?
Always.
And give us thick bone exactly where we want it for this implant. You okay? Actually, let me have that. I'm going to use that instead of this to hold it back. Okay. Thank you. You always tack first, otherwise you're tacking into mush. Which doesn't work very well. You might say, why do we need osseous here? Because it's stabilized. I'll talk to you about it after. It's actually to stabilize the clot, keep it from shrinking. You okay? Yeah, thank you. Aggravating me. There we go. You all right? We made sure we kept enough space for exactly where we need the bone. We're going to get a big, thick ledger bone, but the key is going to be the line angle. That's what people ignore.
Gonna lean against you, my friend.
Talking to me?
Talking to our fantastic patient.
My fantastic patient is also a professional boxer, so it's a good thing you told you. The reactions take over sometimes. You don't do that much anymore, do you? Okay, I don't think so. That way we can make this tooth last. Okay, great idea. Okay. So I'm actually up over the crest because we want to get back some height here, right? Including on the palate. So let's take a look. And then your moist gauze to get that into more ideal form. Okay. Pressure only. We're going to look at the form together in a moment. Your suction that relaxes. Hold on a second. Let me get this in position. Hold on a second. I tugged on it a little bit too much. There we go. Thank you. Right in there. All that stuff. And right here. Thank you. Okay. You're going to have, now if you look, it's going to be a squared ridge, and that is the key, is the squared ridge, and we're going to talk about that. Okay, here's a little more of that. Thank you. We're rebuilding the palate as well, so this is through and through. Let's look and see. Thank you. You take that out, please. And because of what we did, I'm going to extend it even more. This is going to be passive. And I'll show you, it's still not passive enough to me. It needs to be more passive. Okay. Any pain whatsoever. Can I have a 15, please? You would tell me? Here you go there. Such a home stretch. I was getting rid of my whacking. Thank you, Larry. Okay, now. You know, the membrane is right up against this tissue. That's called a secondary reflection. We have to do. So breathe up. I'll start like so. We don't. The flap binds against it. No pain. These are the last little steps, okay? But these steps will make the final difference in the results. So, put this one on. Thank you. Full thickness under here. See that? Of a secondary reflection. Right up the spine here. You okay? I should have handed you that, Larry. Sorry. Would have been more logical for all of us. Watch what's going to happen in a moment. That's what did you do again? After saying I should have handed it to you. There we go. So I just freed this up here, okay? Going to do one more step, but let me show you what we have. Thank you so much. Take that out, please. Just that. Look what it just did. We're going to do even more. Are you okay? Okay. One more little step, and then we put the stitches, okay? Section right here. Here. There's the entrance right there. There we go. And now you'll see. That's all I had to do, kiddo. Now we're going to check it, and I'm going to put some stitches, okay? That's it. Good. And you'll get back 100% of this bone. Can I have the cytoplast suture? Hold on. Will you reflect for me, please? Again?
Sorry, but the check.
No, not yet. Nice idea, though. I can see why you thought that. Thank you.
Thank you.
Now take that out so I can check. Perfect. See how passive that is now? Perfect. Okay. Do you need a break? Seriously, you want to rest your jaw or anything? Well, we're not going to get a beer now, Larry, I guess. Man, pushy people.
Alright.
The beer wasn't for you. The beer was for, oh, the break was for you. Okay. Bite down, please. Are you okay?
Mhm.
You know, Pat, you want to say, are you okay? Open wide, please. There you go, man. Don't close now, okay? Don't. Perfect. Okay. We're going to have some dissolving and some non-dissolving stitches, okay? I'll use as many dissolving as I can, but I need a few that aren't to hold this position, okay? No pain. I'm not going to stitch your chin in. It makes it really hard to chew. That wouldn't be very nice. Take that out now. Now, with just one suture, look how passive that is. And we did a lot of regeneration, buccal, palatal, and crestal. Dominique?
No.
No, it doesn't matter. I was just going to say what you guys doing. I'm trying to distract you now. What you're doing for the weekend and stuff. Are you okay?
Mhm.
Few more stitches and you're done, okay? Hey, boo-boo. Thank you. Relax your lip, please. That's okay.
Oh, I'm sorry.
I just don't want to get in. That's fine. Don't worry about it. Okay? But thank you. Okay. You okay?
Mhm.
Think there's some leaning against you, okay? No pain? Sorry, I'm asking the same questions over and over again, but I really think they're good questions, so. Open wide. You're really an amazing patient, I have to tell you. And we're going to have plenty of bone here afterwards, don't worry. You can see how passive this is. We're not forcing tissues anywhere. All because of incision design. There will be 3 non-dissolving, and then the other 4 or 5 will be dissolving, okay? Suction right here for me, please. And again, you can see the passivity of it. Thank you. Stay right there, kiddo, okay? Doing great. Thank you. Now, if you want a break, need a small chromic. Actually, start with a large. Can I have a mirror, please? Let's look, okay? No tug at all, very passive. Now he's back to the vertical. Can you suction this vertical for me, man? Right here, right here. Got it, thank you. Okay, nice and passive. Okay, I'm going to put a couple more dissolving stitches. You're done. You know what I'm going to ask you. Do you want a break? Okay. You're so cool. If you were Benefit concert, you'd be Kool-Aid. That's how cool you are. Bite down a little, please. Are you okay? Little tugging here now, okay? These should not hurt. These are dissolving now. Probably all done with a non-dissolving. I always say it that way till we're done. And honestly, we got exactly what we wanted here, so this is good. There we go. You okay? Thank you. I need a small one too. You want me? Stay right there, okay? Thank you. Go to the other one here for the small, and then we'll go to the other side, okay? You probably have 4 more stitches after this one, and then you're all done, okay? And they should all be dissolving, which is nicer for you. You rest a second, okay? We're just going to get another suture. It's right here. Doing all right? Okay. Thank you. I have a mirror. Thanks. Open, please. You let me know, kiddo. Thank you. Okay. Perfect. I'll suspend that right up. All right. Good. I just have to put 3 on the other side and you're done. Turn toward me, please. Way over toward me. Thank you. Okay. Bite down for me, okay? Beautiful.
When you make these horizontal extensions, you have to put one here first, of course. No pain? Okay. Always going to ask. Here we go. I think the guy who tortured me as a kid did more for my future patient's comfort than anybody ever could have. Because I was so, thank you, Larry. Couldn't do that afterwards, obviously. You okay? Mm-hmm. Thank you. Open, please. Turn toward me, please. Okay. Thank you. No pain. Okay. Last one. Most likely. I always qualify it. No, you're going to ask the stupid question this time. Okay, so let's just get it done for you. Turn this way, please. Thank you. Okay. Yeah. Don't suture. We don't suture the palatal verticals. Very, very rarely. The end of the suture in the hand. Stay right there. There we go. Okay. Okay, kiddo. Jackie, you all set? Oh. Thank you. Okay, let's rinse things out first and take a look, make sure we don't need anything else, okay? Mm-hmm. This is water. You ready? Let's look, okay? Have another, actually, another mirror lamp. Take a look, and you'll see how passive that is. That's not moving at all on the crest. Okay. Open wide for me. We got primary closure, and it's passive. Thank you. I want you to rest. We're going to wipe off your face, give you a little ice right now. You rest for a minute, okay? Okay.
Misunderstanding, misinformation, propaganda, a poor understanding of the definition of success. This is what plagues guided bone regenerative therapy. Membranes should never get uncovered. It's a compromise. Learn how to keep them covered. Specific materials have to be used in certain situations to regenerate pre-pathologic bone morphology. Learn which materials to use. Very simply put, this is a predictable therapy in the hands of any competent clinician. The challenge is not technical. The challenge is one of understanding. Learn the appropriate definitions of success. What we accept are defective definitions which lead to problems 5 to 10 years post-therapy. Our unique combination of live surgical observation, interactive discussions, and exercises with fresh human cadavers offer this opportunity to all students, all clinicians, to bring guided bone regenerative therapy to a new level. You owe it to yourself, you owe it to your patients. Implant therapy is a proven, highly predictable treatment modality. Implant failure rates after 10 years should be less than 1%. This is not dependent on technical acumen. This is dependent on an appropriate examination, a comprehensive diagnosis and treatment plan, interdisciplinary care, and utilization of the best materials possible. However, this includes more than just surgery, implants, bone, restorative components. This includes understanding parafunction, which in turn includes understanding the component of sleep. If you don't manage parafunction, you don't maximize treatment outcomes. It's not fair to the patient. It's not fair to you. You need to learn how to integrate these simple therapies into everyday practice if you want to truly succeed. It's up to you. Who are you?
Welcome back, everyone. Dr. Fugazzotto is wrapped up and he's getting ready to present. We will give him just a few seconds to get his audio back on, but we are almost ready to go. In the meantime, if you have other questions from the surgery or just on this topic in general, about his education courses, about our product at Osteogenics, please put those in the feed. We have several good questions already, several about flap release, fixation, what types of sutures we used, membrane selection, how to pick the correct size, and several other really good questions. So is Dr. Fugazzotto almost ready?
So first of all, in the world of reality and practice, I apologize. That always takes about 20%, 25% more time under a camera. You're going to move out of the way, etc. And I would never call any patient routine. That is a straightforward procedure that we do all the time. And I tried to think about this the other night, about how many times we've used titanium membranes, because Osteogenics had one way back. I was the biggest Gore user for 5 or 6 years in the country. So I would guess realistically that we've probably used titanium membranes on patients 8,000 times. Not the same patient, a long time. I did veterinary dentistry once when I treated my ex-mother-in-law, but we won't talk about that. So anyhow, so here's what we did. Let me show you a couple of slides to show the flap designs that we used, and then we'll talk about what happened. But you'll notice that I was very demanding about having passive soft tissue primary closure. So let's talk a little bit, okay? Okay, let me go this way so I'm not in the way. Okay, that's better. Okay. So what we're really looking at are two things. You're looking at soft tissue management and material selection. And they're both sort of ignored, because not all flap designs are the same for these procedures, and not all materials are the same. Absolutely not. And I've tried them all, and I tried to substitute other things I thought would be easier. And if the results aren't the same, it doesn't matter if it's easier, right? So we've got to attain and maintain passive primary closure. This was a pretty straightforward case. All we do very long vertical incisions. We then do horizontal extension. We then do horizontal extensions of them. And that horizontal extension will be as long as we think it has to go. You notice I did it at first. I went back and did it more afterwards. And then it's all full thickness. Nothing is partial thickness. It's all full thickness. Okay? That's usually enough to do everything we need. I'll show you one quick little diagram of another flap design we use a lot, but that's not really the purpose of this surgery, obviously. If I had been able to get passive primary closure that way, we would have used something called the rotated palatal pedicle. I need to get out of the way a little. There we go. The rotated palatal pedicle, where we take the palatal flap, we make incision in the palatal flap about 4 millimeters from the base, and we split it with a 1-2 pickup, and as a result, let me get out of the way, we end up extending that flap about 60%. And it's very predictable, and there it is, and it works very well. We didn't need that here. That would have been in our armamentarium. This is something my friends Sergio De Paoli and Stefano Palma Benfinate and I developed in '92, and it works very, very well. However, for a case like this, it was straightforward. And because they're straightforward like that, here are some statistics, and that's really aggravating them in the wrong place. Okay, here are some statistics demonstrating maintenance of passive primary closure. And our definition of success, I'm actually going to walk out of the screen for a moment to show you these numbers, okay? And our definition of success, very simply, was maintenance of primary closure for a minimum of 6 months. No exposure of the membrane whatsoever. And doing that, we kept it closed 96% of the time, which really sounds great unless you're in the other 4%. So we had to deal with that 4%. How did we do it? Well, we already talked about vertical release. We talked about horizontal extension. We talked about full thickness flaps. We talked about the rotated palatal pedicle. Came the secondary reflection. We realized we had to do that. That was what I did at the end when I had my membrane tacked, right? And once it was tacked, I went in full thickness around the base of it and around the palatal corners. The reason I did that is if you don't, when you pull the tissue down, it binds on the membrane. We released, you saw how more secondary everted and used as an is a much more complex design. It's really not the topic today, okay? And when we did that, we contained 8.8% of the time. I expect primary closure for the 6 months of regeneration, if 6 months is what we need. I expect primary closure. And these are a lot of cases. Between the two studies, it's 900 cases. Primary closure, 98.8% of the time. It's very predictable if you demand it of yourself. You saw how many times I went back and I checked the flap mobility. And I know a lot of people would have stopped after that first time. No, that wasn't passive. I would have had to hold that down with the sutures in that position. It's got to be passive. So that's how we take care of tissues. In brief, of course. Look, I realize this isn't like a big surgical seminar with cadavers like we do here about flap design. That's how we do it. However, that's only step one. Step two is material selection. And the problem here is that material selection is often based on what it shouldn't be based on, because we know what works the best. Material selection is number one, based on therapeutic goal. We'll get to that. Number two, based on defect morphology, which leads directly. We're going to show a couple of cases right now. But most importantly, to get out of the way again, most importantly, it is not dependent on technical limitations. I'll give you an example. I went to a very resective perio program long before we had implants. So what happened is we did a lot of root resections. And I went to a perio meeting when I'd been out a year. I talked to some kids who'd gotten out a couple of years before. And they said, well, you're from Boston University, you do a lot of root resections. I said, I don't know, I do them when I need them. They said, we don't do them because they don't work. So now I'm all nervous because I just got out of school. I said, well, how many have you done? They said, none, they don't work. Okay, so I obviously had that person killed. I mean, but the point is, you don't pick a membrane because you don't know how to keep primary closure. You learn how to keep primary closure, and then you pick a membrane. That's the right way to do it. And let's look at why. And then we'll talk. This patient presents again. Okay, there we go. This patient, you don't need to see me anyhow. This patient presents with a defect. Look at the top two slides. This case is not space maintaining. There's no buccal wall to support a membrane. So I used a very dense xenograft, covered it with a resorbable membrane, and went back 6 months later. And that, you can see we have no line angle of the ridge, no crest of the ridge. To me, that case is a failure. It's a failure. I had to retreat it because the membrane collapsed during healing. So then we do another one and look at the top two slides. You say, well, that's space maintaining. That's pretty good. Not really. It's space maintaining about a third of the way down from the apex. Then it's not. Xenograft, packed densely, resorbable membrane. We go back and look. There's no line angle to the ridge. The ridge is collapsed like so. We want a line angle. Failure. That's a failure. My case is failure, had to redo it. So then we'll wake up a little bit and we look at this case, which is obviously not space maintaining, right? So we go in and we do a xenograft and we use a titanium reinforced membrane secured with fixation tacks. And we square the membrane like you saw to get a perfect ridge. And then we tack it and then we get primary closure and then we keep primary closure. And look what you've got. You've got a perfect line angle to this ridge. And now I can go in and I can put an ideal diameter implant and have a perfect line angle with a certain dimension, which I'll show you in a minute, of what I demand when I do guided bone regeneration. How about this one? Look at that ridge. I can definitely get a thin little implant at a bad angle in there. That's useless. I can use a block graft, but if I use a block graft, I have to go to a second site. And if I use a block graft without a membrane, the line angle resorbs anyhow. If I use particulate with a resorbable membrane, line angle resorbs. So I used a titanium reinforced membrane. And look what happens. We got primary closure at 6 months, and that's reentry. That's a perfect ridge to put an ideal diameter implant in a perfect position. Okay? Let's look at this one. Last case for now. That patient has a ridge that's approximately 1.5 millimeters thick, approximately. So what do? Again, titanium reinforced membrane with particulate material, and this one is 8 months later. Look at that line angle. That's a perfect ridge, except today it's not. Today I would have made the ridge even wider buccolingually, so that when the soft tissues came over it, I would have had more tissue above the bone, coronal to the crest to work for my aesthetics. But that's my definition of success. Following guided bone regeneration, it's pretty simple. I want sufficient bone, and this is it. There's no maybes. I want sufficient bone to place an implant of appropriate diameter in an ideal implant position with a minimum, this is the key, a minimum of 2 millimeters of buccal and lingual or palatal bone at the crest. Sorry, let me get out of the way again. At the crest, to maximally support the soft tissues as well. At the crest. And I've been using this definition since 1990. And people how many of you put an implant in number 19? You put it in, you put a crown, it looks great. 5 years later, you're seeing resorption and you're seeing the margin of the crown. You know why? That's all because of 2 bad releasing incisions 5 years ago when you did it. You didn't do adequate releasing incisions, which means you didn't get adequate reflection for primary closure with a titanium membrane. So you used a resorbable membrane on a ridge that's shaped like this. So as it regenerates, you got thick bone down the base, but you've got a ridge crest like that at a peak. You put your implant in, you've got thin bone in the buccal, all of a sudden it starts to resolve the function. This is my definition of success for guided bone regeneration. If I can't get 2 millimeters at the crest, I got a problem. If I put an implant in that doesn't have a dehiscence of fenestration and the bone is thin and almost translucent at the crest, I graft it at the time of implant placement. And if you have a non-space maintaining defect, you cannot get this line angle predictably unless you use titanium reinforced membranes. I'm not the only one. Massimo Simeone's been doing this for decades. It works. It's that Sasha Giovanni, forget about it. It works. I need a perfect line angle. I don't want to have these break down over time. I mean, I've done about 45,000 implants. I've done a lot of implants, and we've all had our problems. But this is predictable, and that's what matters. That's my definition of success. I'll put this up before I answer questions. I'll leave that up. There's my email. I answer emails. You call me, I answer emails. Okay? There's Jackie's email, phone number, and she will answer them as well. So let's talk now, but you'll be able to get in touch with us. And of course, Shane has my contact information. Whenever he needs some fishing tips, he calls me. So, do you guys have some questions you'd like to go over?
First question. Graft material selection. What graft material were you using?
Okay, but however, that's number 3. Number 1 is flap design. Number 2 is titanium reinforced membrane. Then I was just using a simple FDBA cortical cancellous mix. But the truth is, that's not what's giving me the success. What's giving me the success is the titanium reinforced membrane and passive primary closure. Why did I even put a graft in there? I put it in there because I've got to stabilize the clot. I don't want it to shrink. It was simple FDBA. And that was a very straightforward situation. That's what I used.
Okay. So it was a cortical cancellous mix of FDBA. Got it. Membrane selection, you talked a little bit about why you picked PTFE. How do you pick the size before you open up the flap, before you see the defect? How do you know what membrane size to have ready for the surgery? Okay. So in this specific case, you could look at the patient, and I knew she'd had an implant. Somebody failed. They did it 3 times. They took out the buccal bone. So I knew it was going to be collapsed. If I have a non-space maintaining defect, by my definitions for myself, it has to be a titanium reinforced membrane to get the crest. Well,
That's a single tooth. So, and I'm not saying this because you're on here, Shane. You know me. I'm osteogenics. That's a perfect design for a single tooth. Well, I knew that was the one I was going to use. However, not to sound facetious, we always have dozens of each size here because we do it so much. So we didn't open it. Well, actually, Larry did open it because he's very experienced. He knew. But I could tell just it was a single tooth. I knew it was going to be titanium. If I have a question, I don't open a membrane, resorbable, non, etc., until the time. That, of course, a CAT scan.
Okay. Suturing. What types of sutures were you using and why? And what knots were you using?
Okay. So I believe in suturing, right? Okay. So I'm not going to use a non-resorbable suture on a releasing incision because it's miserable to go get it. So that was simple fluorochromic gut at the base of the release incision, 5-0 chromic gut when I went through the papillae on the sides of the flap. When I went over the regenerating area, those were just cytoplast PTFE sutures because they tie easily. If the patient gets a lot of swelling, they slip slightly so they're more comfortable, and they're a very easy suture to utilize. I think it was a P3 needle. I have to look, I know what I like, but I don't know what they're called. So that's what I used. Why do I use those? If I want a non-resorbable, I think that's a very, very easy, predictable suture to use. I had trained with gore sutures way back, so I'm used to using this kind of material. But I never use a non-resorbable on a vertical. It's miserable to go get them.
Gotcha. Makes perfect sense. What about the knots? You do like a double, single in reverse direction, or what's your?
No, I'm a very simple country boy. So basically, I take it, single flip, tie, single flip, tie, single flip, tie, 3 times in the same direction all the time. None of this double, go back, another double, lift my left leg. No, single flip, tie 3 times. That's it.
So 3 singles all in the same direction.
It's easy and it works,
Okay. Awesome. You did not decorticate the bone. What are your thoughts on decortication? Do you do it ever? If so, when?
I always decorticate the mandible. There wasn't really any cortex there to decorticate. I mean, I was right into the marrow cavities, so I had no need. I always decorticate the mandible, but I didn't see any reason, nothing there to really decorticate on this one.
Okay.
When I do decorticate it, I do not use a burr. I use a piezo unit, little tip of it, and just make little holes in it.
How deep do you go on that? Like 2
Well,
millimeters?
a couple of millimeters, depending on the case. If I've got a ridge that's only 2 millimeters thick, I'm not going to go through it. Usually a couple of millimeters. You can tell when you're through the cortex. Everybody's a little different, right? The average patient, a couple of millimeters. When I treated my ex-mother-in-law, it was about 8 millimeters because she's a gigantic mastodon. It's different.
When tacking,
Yes.
is there a risk in hitting the roots of the neighboring teeth when you place tacks or screws?
That's a really good question. Let me back up to the tacking why first. The reason I tack the membrane is you have to make your membrane immobile. If you don't, you'll get some membrane movement during healing, and that increases the chances of losing primary closure as the flap gets irritated. Therefore, even when I do a resorbable membrane, I tack it. So for example, let's say I took out number 30. I had the walls were intact, but they were very thin. So maybe I put my implant in, whatever. Maybe I just graft and I put a resorbable membrane over because it's space maintaining. I'm still going to tack that. These are small little titanium tacks. If I used a resorbable membrane, I'd leave them in there. If not, I'll get into the answer to your question. I make my reentry verticals exactly where my initial verticals were, reflect the flap, take out the tacks, take out the membrane. Is there a danger to hitting the root? There is if you're not careful with the angulation. The truth is they're only 3 millimeters long, and I'm sure I've hit a root before. I've never had a patient with any problem from something like that. You can pretty much see where you're going. They're not that long. And I don't think it's cataclysmic if you do that. But I tack everything. If you don't, you will get more loss of primary closure.
So you tack everything, avoid movement of the membrane if it's resorbable or non-resorbable.
Absolutely.
Got it.
And I do not use those guns that you can shoot in the tack with for a couple of reasons. One is in delicate bone, it'll crack the bone. 2 is it reminds me too much of where I grew up. I also don't use the screws to secure the membranes because it's aggravating. because it takes too long to screw them in, honestly. And you swing it in, the membrane's moving. If I was not under a camera, from the moment I pick up the tack till the tack is in and the instrument is off, averages 17 to 19 seconds. Okay? You put it down, tap, tap, tap. Don't just take it off. You'll pull out the screw, the tack. You noticed I put an explorer in between the tines, held it against the tack head, took it off in a turning motion. 19 seconds, 7, whatever, it's very quick.
Did you tack the lingual in this case?
I did not. It's very hard to do that unless somebody can open very, very wide. But if you remember, I took the membrane, I took a mirror handle and I curled it so that it went in out on the lingual the titanium slightly curling toward the crest, the flap over it, tacked here, it's not going to move and it's not going to spring back.
How do you decide where?
Lingual palatal, so I just do the curl like so.
Is the curl? Is that pretty much? I mean, that's like every time, or it's really case to case.
Yeah, every time. Sure, you got it. You just take it's all titanium here, just whoosh, like so. I end up trimming off usually the non-titanium little head here because I want all my titanium supporting things. And in this case, we had no palatal wall either. I had to regenerate. Well, but I had to regenerate about 4 millimeters of palatal wall as well. So we didn't just do a buccal ridge augmentation. We're going to get about another 4 millimeters crestal here as well, and it's going to work. The reason I added pref gel and Emdogain because I had an attachment loss on the facing side of the incisor. So why not try and get reattachment of the soft tissues there as well? It's only another minute.
Any specific membrane trimming suggestions or tips?
Yeah, that's really important too. Do not trim membranes with a scissors. Trim them with a 15 blade. With a 15 blade, you can really go wherever you want very delicately, except with the only time I use a scissors is if I'm cutting through the actual titanium. I know they used to tell us don't cut through the titanium. Don't listen to them. I know they used to tell us you have to be 3 millimeters from the vertical. Don't listen to them because it's tacked. It's not going to move. So trim with a 15 blade. Again, we're obviously not doing hands-on right now, and only use a scissors to trim through the titanium. I'm going to say something I realize is not agreed with everybody. I insist on passive primary closure on every membrane I do. So just so you know, get more soft tissue and better bone.
Perfect. Can you comment on where you decide to place your tacks?
Yes. Oh, you want me to answer? I thought you were just asking me if I could comment. Sorry. You've got to place at least 2 tacks if you know the membrane's going to rotate. And it really goes by the defect morphology. You can never tack where you're going to regenerate because you'll close down your dimension. So I tacked just lateral to where I was going to regenerate. That's all I needed. You need at least 2 tacks lateral to where you're going to regenerate. On a big mandibular posterior ridge augmentation, which we do all the time with these membranes, I'll cut my membrane so I leave little wings on the sides. If the membrane's here, wings past the regeneration and tack there. Just tack away from your regenerative site. At least 2 tacks. That's the key.
Next question. What? No, we did that one. Hold on. It'll be
deja vu.
Why did you not condition the neighboring root surface with something like Emdogain?
I did. I put on pref gel to condition the root, and then I put Emdogain on it. The one on the other side has no attachment loss. The CEJ in its relation to the bone crest on number 8 is perfect. So there's nothing I had to do then. It's just going to generate a normal reattachment apparatus. Number 10, I had attachment loss. So I put Emdogain. I put pref gel, rinsed it, Emdogain. I did do that. So I conditioned where I had to get reattachment. The other side, it's just going to attach normally. I mean, kind of Ali showed that certainly, and some papers we did.
Okay, great. There's a question. Your thoughts on PRF, PRP? Maybe this is a 2-part question. Maybe we stop and answer that part first.
Okay. I have a lot of experience with the blood products because the man who invented PRP and put the first commercially available machines out has been a patient of mine for 30 years, although he doesn't live up here full time anymore. So I use that a lot. I've used that a lot. I've used PRGF. I went over with a knee tour and used that a lot in Spain. I do not have any experience with PRF. I'm still do not see any convincing data. I'm sorry, you may have data. We have data because we don't have an accent. I have no convincing data showing me that it helps with bone regeneration. There's plenty of data for soft tissue. Do we still use PRP sometimes? Yeah, sure. But if I'm doing a soft tissue graft, I use Emdogain and get the same result. So my experience is not that great. When we were using all particulate materials, though, I loved using it because it congealed it together, which was very nice. Now, of course, you don't have to do that because you can get them different ways if you need them. I've never used PRF. I have a lot of experience with PRP. Made the soft tissue fantastic. I don't really know of any conclusive, nice studies showing any of them resulting in superior bone growth. If there are, it's just by ignorance for not knowing them. I use a lot of Emdogain.
Yeah. Immediate implant placement in this situation, did you consider it?
No, and again, that wouldn't be a bad thing to talk about another time, is the algorithms I have, and it's not, I'm not trying not to answer you, but it's much more than a quick answer. It's a significant discussion. No, I didn't, because the parameters weren't right there, because I'm in the aesthetic zone, and she had although she had scar tissue there, she had a thin biotype. The things I look at, first of all, there's immediate implant placement and there's immediate provisionalization. These are obviously two different things. Because in our office, when it's appropriate, we take a digital scan, send it to the laboratory, 15 to 17 minutes later, we have the design back. We print a provisional crown in our 3D printer. So within 40 to 45 minutes of the implant going in, you're walking out with a provisional crown screwed in that we printed if we think it's appropriate. So we have no problem with immediate provisionalization either. Immediate placement is going to depend on defect morphology. That's it. Immediate provisionalization is going to depend on defect morphology, biotype, deep bite, not deep bite, and patient parafunction. One of in my opinion, we're off the course a little bit. The primary cause of implant failure, I believe, is force. I published a couple of papers with mean time in function of over 10 years in function with thousands of implants. Any implant we had fail in a healthy patient after 5 years was due to parafunction because we weren't getting them back enough. At any rate, back to your question, immediate placement depends on biotype and defect morphology. I didn't feel the defect morphology was proper, but that's a bigger discussion to answer properly. And I don't like people don't answer it properly because you get bad ideas. Immediate provisionalization is defect morphology, biotype, deep overbite or not, and parafunction. We do immediate provisionals on full arches. You can print up take all the teeth out, put 6 implants in, and we'll again design, print within 95 minutes of the sitting up with the implants. You're getting a full arch provisional put in. So we do a lot of immediate provisionalization. Not this case, there are too many factors against it, which again is a big discussion. I'm sorry.
Okay. Thanks for that answer. I think that's a good starting place for that answer. Okay. What did you use to disinfect the area?
Nothing.
Or
I just cleaned it out. Saline. I made sure that I had clean gloves. No, I'm sorry. Nothing. I don't do root treatment with antibiotics. I don't mix antibiotics with bone grafts. Nothing. We just debrided everything, cleaned everything up, and put our graft and membrane. And in this case, Emdogain, because of what we're doing. I don't put
thorough physical debridement. So just mechanically clean it.
Yeah, mechanical debridement. Yeah.
Got it.
And I don't treat politicians because they have so much more infection around,
I think you already answered this question. We had a question about do the tacks stay in or come out when you take out the membrane? You said with resorbable.
If it's resorbable and I do not have to re-enter to place the implant, because if I've got number 30 again and I've grafted, it was contained but thin, I'm going to have a big squared ridge here, right? So I don't have to re-enter. That'll be flapless surgery. If I don't have to re-enter in a resorbable membrane, I leave the tacks in. If not, I take them out when I re-enter for implant placement. On the titanium reinforced, when I go to do the implant, same vertical incision as when I first went in, and just take the tacks out then. When you take the tacks out, don't flick them out because you're going to blind somebody. You put a suction tip right here, you lift it slightly with a molt, it's sucked right up. So that's when.
What type of temporary will the patient be wearing post-op?
Okay, and I'm not being a wise guy. I never use the word temporary. I use the word provisional because in patients' minds, it's a little practice management tip. In patients' minds, something temporary has no value. A provisional is a treatment step, right? So what I would have liked to have here is a bonded retainer. She didn't want to do that. Okay. She has an Essex appliance. I hate flippers or whatever you want to call them because they smash on the tissues. She had an Essex, and that's what it is.
Okay.
Which I
what about
adjusted, of
post-op
course.
instructions? What are your post-op instructions for this patient?
Let's see. They load with antibiotic night before or that morning. I suggest they load with an anti-inflammatory as well. Her post-operative medications, first of all, are very simple amoxicillin. If it was a very complex case, I'd give her augmentin. If it was a very complex case, if it was a simple case and if it was a complex case and she was allergic to penicillin, I don't think clindamycin does anything. She'd probably go to a Levaquin or something like that. They'll get an anti-inflammatory, assuming they can take one, and I'll have them alternated with Tylenol, assuming they can take that because it's more effective than anti-inflammatory alone. I use a Totalac 400 TID for an anti-inflammatory. I don't use Medrol dose packs. I give very few pain medications. I bet we don't write a pain medication every 3 weeks because you're gentle with patients. You're in and out and use the anti-inflammatories. She cannot, here's very important. She has a removable appliance. She cannot chew with that removable appliance in, period. Not, eat something soft. No, not it might fail. It will fail. You chew with this in, that's why I say to people, it will fail, you'll do the surgery again, and you'll pay for it again. Because if you don't say it that way, first they have chicken soup, then they have chicken bones, and they have chicken poop, and they screw up the whole thing. They cannot chew on it. No hot liquids or any food till the anesthesia, I see use the word Novocaine, of course, till the Novocaine wears off. Then the last instruction to give them a little laugh is I say, don't eat anything you don't like. Because everybody should laugh when they leave. You want people laughing as they walk out, not upset. That's my whole post-op instructions. Very simple. Very simple. Those non-resorbable sutures will come out in 3 weeks. If I'd used all resorbable, as I would in some cases, I wouldn't see this patient for a few months and I'd take an x-ray. And that's it. There are not a lot of follow-up visits, A, because they don't need them, B, because it jams up your schedule. But it's because they don't need them. What does she need? She needs a suture removal and a scan in 6 months. That's it. Doesn't need anything else.
Well, that's going to be my next question is a post-op visit. So you're saying 3 weeks for suture and then 6 months for membrane and implant placement?
3 weeks 6 months for this one because it was such a big ridge rock. If it's a nice contained defect, it may be 12 weeks I take it. But this one is 6 months. And because she has non-resorbable sutures, they come out in 3 weeks. If she had all resorbable sutures, pardon me?
No, I'm sorry. I thought you were done.
No, one more thing. If she had all resorbable sutures, I wouldn't see her for 6 months unless she wanted to see me. So
okay. When you remove this membrane, in this case, at 6 months, I believe you said, will you place the implants then, or is there any sort of delay between membrane removal and implant placement?
Implant goes right in, and in this case, I'm sure I'm going to do a connective tissue graft at the same time, just to bulk out the tissue even more, the soft tissue. But implant goes in when the membrane comes out.
Okay.
And let's be honest, I'm not being a wise guy. I mean, how long have it? This is a nice technique. People say, it takes so long. You're going to make the same verticals. You go take the membrane out and put the implant in. No offense. That whole procedure is like 30 minutes. And how long does it take to take an implant out, take a membrane out? It peels right off after you take the tacks out. And how long does it take to drill a hole in an intact bone and put a piece of metal in it? So this does not complicate your life. What it does is give you predictability long term. And it really does.
So there's a flap question. It says, I'm just going to read it word for word so I don't. So you relieve the flap facially until you get passive movement. That's relieving tissue along the periosteum, which can go almost below the nasal bone. Also, how far distally and mesially do you make the incision from the surgical site?
Sure. And that's going to depend on what it looks like. Let's assume that this patient came in and she had good attachment levels on the facing surfaces of adjacent teeth, and she didn't have that big collapse. She just needed an implant. I would make the verticals just within the edentulous site papilla sparing and just put an implant. In this case, that wasn't the case, obviously. One tooth over on each side. And it's long verticals, and it's all full thickness. How long do I make the horizontal extensions? That depends on the case. In this case, I made some. When I went back, they weren't long enough, so I made more. Then it's all full thickness. And I was up to the entrance to the nose. I went all the way up to the entrance to the nose. I could see it. I went up as high as I had to and reflected full thickness off the nasal spine as well. So my reflection is purely a function of whether I've got adequate flap mobility for passive primary closure after I place my materials. You saw me go back and extend it because it wasn't enough. I've gone 20 millimeters on each side if I had to. The point is I'm going to get that thing covered passively.
Related question, how far did the vertical incision go on both sides? How far did the verticals go?
You mean how far up?
Yeah.
Oh, they go way up into the fold, all the way up into the fold. And again, I make sure they're long enough that I think I'm going to get the mobility. So my initial incision was way up, and then horizontal extension, I think like 6-7 millimeters at that point, right? So I just kicked the camera. I hope it didn't do anything bad. All the way up, horizontal extension, 6, 7, 8 millimeters, full thickness. After I did my work, said, oh, this isn't passive enough. I extended more. I think I probably ended up at about 15 millimeters, 12 to 15 millimeters horizontally on each one, and then all full thickness. Yeah. Way up, horizontal, and you're constantly checking it before you suture.
Got it. Says after a healing period in today's case, what are you planning to do to increase the depth of the vestibule between 8 and 9, thick muscle attachment, and zenith
point? Good question. That's easy. Number one, I've positioned the tissue coronally, right? So when I go back in to re-enter, I'll make an incision to the palate, and I'll bring that over to the buccal with my verticals, and that will reposition my vestibule to the proper depth, and I'll take out the membrane, and I'll put my implant in, okay? So I will just go from the palate right over the membrane, etc. At that time, if I think I need a frenectomy, I'll do it with a laser when I put my implant in the same day. I may not need that when I position my tissue back down afterwards, and I'm pretty sure I'm going to put a connective tissue graft under here. I just put an allograft. It's nice and easy. I'm pretty sure I'm going to do that. You still there? You having a beer?
I mean, there's some of these questions have already been answered. They're asked a few different times.
Checking that.
There's a question I think you've kind of answered, but maybe a more specific. When would you consider a collagen membrane instead of a PTFE membrane?
If it's a space maintaining defect, and I use them a lot. If it's space look, here's the way I've always looked at things. If I can get equal results, truly equal, use the easier one. But they have to be truly equal. If I can get equal results, and and this one is less expensive than this, use that. But it starts with equal results. So I'll use a resorbable membrane when I have a space-maintaining defect, which is about 30% of the time. And you know that better than me. You know my ordering pattern, but about 30% of the time.
Yeah. Do you ever have soft tissue defects after getting primary closure, i.e. losing the papilla? And follow-up question there is, do you have any thoughts on using vertical incision versus envelope flaps?
Yeah, I'll go start with the second one. I'm giving you opinion now. I have found for decades I cannot get the same degree of flap mobility unless I envelope a lot of teeth. And I don't like exposing that buccal bone and all these teeth, this thin crestal buccal bone on these other teeth. It doesn't seem to make sense to me. So that's number one. Number two is, do I lose the papillae? If you notice, my initial incisions started palatal of the papillae, and I lifted the whole papilla intact and then went back again. So I don't have that problem. Do I get tissue dehiscence and membrane exposure? 1% of the time, as you saw in that slide.
Okay. When you do get the 1%, the time you get the exposure, how do you treat the exposure?
I kill the patient. Honestly, that 1% is, I never get in the anterior. Maybe in the posterior where I've done really a big vertical type of thing. There's nothing you can do. If you get it, you just keep them using chlorhexidine or something and hope it doesn't get worse till you get to a point where you're comfortable taking it out because the bone is mature enough. If it keeps getting worse, you take it out. These things have all me reoppose the flap ends. That doesn't work. It just never works. You just make it worse. I just don't touch it and tease it along as I can. Fortunately, it doesn't happen very often anymore. I mean, even that other paper, which was 25 years ago, was only 4%. Now it's 1%. So
what I'm hearing is you try to keep it clean and nurse it as long as you can.
I'd like to get at least 8 or 10 weeks, so I've got some bone consistency of osteoid. But you do what you can do, right? The best way to treat a complication is, let's face it, don't have the complication. That's how you treat a complication, right? So
Do you ever use tenting screws?
Nope, because I have titanium reinforced membranes. I've used them. I've used the ones that are bone. I definitely am not using non-resorbable ones. It never made sense to me to stick something in where I'm regenerating that then I have to take out and leave a defect from it. No, I don't. I've got a titanium reinforced membrane that's tacked. And as you know, I do big posterior areas of like 3 and 4 teeth as well and get it where you want. I don't use tenting screws, no.
Okay. What was the name of the prep gel that you used before you placed the Emdogain?
Oh, that's the one, again, not to use a brand name. I mean, that's the thing that Straumann sells. It's just EDTA.
Okay.
I don't know if anybody else is selling it in that form or not. If not, even if you don't want to use their Emdogain, they'll just say the prep gel. It's just EDTA.
Yeah. Do you give Periodex after surgery?
No, it tastes disgusting. It tastes disgusting. It stains the teeth, and there's no evidence whatsoever it helps. There's some studies showing it delays fibroblast growth and migration. Some studies saying it's better for it. I just don't use it.
Okay. What kind of connective tissue graft?
We're out of fact. I mean, this is an opinion, obviously. You know.
What kind of connective tissue graft will you do when you come back and place this implant with this patient?
In this one, I'll probably just do an allograft. If not, I would go to the distal wedge, take a wedge, shape it, and put it in there. But in this one, I'm just going to use an allograft. I'll fold it over itself, stick it under there. It'll work fine. You know.
Okay. What about the possibility of using connective tissue graft in the case before bone augmentation?
She's already got enough scar tissue. I don't want to do a surgery and make it scar even more. That was difficult to reflect at first, as you saw. So I don't see an advantage there. I don't do that very often because you just make more scar tissue. And I think it makes your flap mobility a little more difficult. And I do it afterwards. I know some people do it at the same time. Maybe it'll cover the membrane. You won't get exposure. I don't find that. I find I'd rather have a thinner mobile flap because you could almost see that membrane through the flap when you looked at it when I sutured. I'd rather have a thinner mobile flap and I'll thicken it later. The mobility is what matters. She was pretty scarred. Remember, she'd had 3 or 4 surgeries there already. Thank God she stopped doing it. I mean, you know.
Yeah. Well, we have answered all of the questions. I appreciate your time. I think that was about 30 minutes of Q&A. That was fantastic. The surgery went probably much faster than myself and many of us expected.
And again,
appreciate your time.
That's 25% longer than it should take, but you know, I was under a camera. And as far as questions, I have to tell you, Shane, you answered the question of the reason for my existence once I met you. I just want you to know that.
We all need that. We all need that person, that inspiration. You do a lot of live courses. I have had the pleasure of attending several of them.
Yep.
We showed you the course schedule earlier, and I know people can also go to fugazzottoinstitute.com to get more information there. Can you just talk a little bit? I know that some of the courses that you do also have incorporate cadavers and some of the if somebody comes to your course, what should they expect?
Okay, couple of begin, and I'm not again trying to whatever. You're going to get the truth of what I really do, and they're going to see complications and mistakes as well because everybody has them. I believe the best way to learn is by watching live procedures and then having extensive interactive discussions and hands-on. With the bone graft course, as you know, you watch a bunch of live procedures. We discuss them in detail and look at a bunch of presentation slides, discuss those in detail. Then you work on fresh human cadavers, not embalmed, fresh. And it's 2 people to a cadaver assisting each other. When we get to the immediate course, that's something that you should really bring your assistant to because Larry will teach them their role in what to do and how we deliver the provisionals, how we do full arches, which approach we use, when to use an FP3, when to use an FP1 or 2, etc. The biggest thing I would say, and also we incorporate a lot of neurotoxins. I'll show you how to use them because you have to use neurotoxins to control this parafunction with patients. And I would honestly say the biggest thing about them is it's just like this. It's informal. They're just informal. It's an open exchange. I mean, and I'm not again saying this because one of the reasons Shane and I are friends well beyond this is because you got to put things in perspective in life, right? You've got to enjoy it too. My goal is to walk out here and say, yeah, I can do that. Why not? And no, I shouldn't do this, and here's why. We've all got mistakes. I've been doing this a long time. Plenty of stuff I do differently than I did. I just say they're very intensive, hands-on, interactive, experiential courses. But thank you for asking me that.
Awesome. The last question that I skipped over earlier is what type of fish are you catching?
Well, as Shane knows, I've been going, this is amazing. I just realized I've been going out to Rockport, Texas fishing. This is my 39th year, which is crazy. The gentleman I used to fish with, I used to take my dad all the time. He passed away. I fished with his son, who is now 50. I met his son when he was 11. So right now, you go down there fishing for reds, of course, saltwater trout, maybe pick up some sheep's head, things like that. It's just wonderful. And as Shane knows, ship down a case of wine, do some fishing, drink some wine later on, and have some fun. That's it, you know?
That's the life.
Right? We're not here for a long time. Nice to have a good time. I mean, you got to be serious, but you have a good time too.
Well, thanks, Paul. I really appreciate your time. Appreciate sharing your knowledge and experience with us, and thank everyone for attending. Really appreciate your time today as well. And I believe remember that a feedback survey will be sent shortly. And that is it. Thank you so much.
Okay.
Appreciate it. Have a great weekend.
Thanks, man.
Bye, everyone.
Thank you, everybody. Bye.